pleasure to introduce Dr. Courtney Fitzhugh for the diversity and inclusion activity that we have this month. And I would like just to talk about a little bit about Dr. Courtney Fitzhugh biography. Dr. Courtney Fitzhugh received her bachelor in science in magna cum laude from the University of California in 1996. In 2001, she went from the University of San Francisco and she got her MD degree. During her medical school, she participated in clinical research in NIH. In the training program, she studied with Dr. John Tisdale at the NHLBI. After her medical training, she joined the residence in internal medicine and pediatrics at Duke University Medical Center. And in 2005, she did a combined adult hematologic and pediatric hematologic oncology fellowship. Dr. Courtney Fitzhugh have a lot of research publications that you can go into her page and we can share with you that link, and you can find all the research and publications that she have in her page and in her CV. Thank you, Doctor, for being here, and we are delighted to share with you these moments. If you have any question, it will be my pleasure to answer your question too.
Okay.
It's on you now.
All right, so hi everybody. I guess I'll just, hi Mahogany, I heard you're out there. So I'm gonna just start by talking about myself. I grew up in California and pretty much knew I wanted to be a doctor when I was a child because my father was a family practitioner and I used to work in his office as a high school student. And I went to UCLA, had an absolutely wonderful time. And I just, towards the end of college is when I started getting interested in sickle cell disease, just from reading about it. I was, like I said, I was interested in family practice initially. So I was interested in just taking care of children and adults, that continuity of care. I was really interested in the fact that it affects pretty much any organ. So every patient could be different. There's a lot of pain associated with sickle cell disease, and I felt it was an area that I could be helpful and make a difference. So when I was preparing for my medical school interview, one of the medical students asked me what my dream for the future was, and I just said, I want to cure sickle cell. I never thought I'd be in a position to be able to do that. So I went to UCSF for medical school, and after my first year of medical school is when I started doing research, and it started in the lab. And it was a great experience, but I realized during that time I wasn't really interested in working in the lab. I remember I was working with a postdoc, and he told me that I talked to him too much because he wanted to just be able to work by himself. And so I loved seeing the patients. And so I heard about the NIH from the SNMA. I went to a meeting, and somebody from NIH was there, and he told me about this program called the Clinical Research Training Program. And he told me about this young doctor who was at NIH who was doing sickle cell research. So I got really excited about it, and I applied. And when I got there, I told him I wanted to work with him, but he said, no, let me just introduce you to a few other people. And so I met Dr. John Tisdale, who was just opening his lab at the time. And he wanted to develop a cure for sickle cell. People have been doing bone marrow transplants for children, and they're using high doses of chemotherapy in order to completely wipe out the patient's bone marrow and replace it with that of the donor. And the early results were successful, which was exciting, but he was an adult doctor, and most adults with sickle cell disease can't tolerate high doses of chemotherapy because they have organ damage. And so, so I decided to work with him, and my primary project was a mouse project where we were studying a new approach to curing sickle cell. We wanted to, instead of completely replacing the patient's bone marrow with that of the donor, we wanted to create a mixture of donor and patient cells. And the reason why it was okay to have a mixture is because sickle cells sickled red blood cells last only about 5 to 20 days, whereas normal red cells last about 3 months. So as long as about 20% of them are coming from the donor, it's enough to take over the bone marrow and cure the patient. So I had this mouse transplant project. It worked really well. And I also got to see the sickle cell patients in clinic with the doctor that I initially went to the NIH to work with, Dr. Griffin Rogers. I got to run on the bone marrow transplant unit with Dantes Dale. I wrote a paper, I wrote a protocol. So it was a really productive year, and I had such a fantastic time. And also both of my parents are from the East Coast, from DC. So it was nice, since I was a California girl, learning that I could actually, I liked being on the East Coast. So it was an amazing year. I went back and finished medical school. And I guess during that year was when I first heard about med peds. I was trying to figure out how I was going to specialize in sickle cell from family practice, which really wasn't going to work. So when I heard about med peds, it was perfect because I love taking care of adults and children. So I went to Duke. That was challenging, but very rewarding. And I chose Duke because not only did it have a great med peds program, but they had a great adult and pediatric sickle cell program. So I worked on 2 projects as a resident. Both were chart reviews, but pretty impactful. And I just loved it. And so when it's time to do fellowship, there wasn't really any or rare combined adult and pediatric hematology programs, but there was one at NIH. So I'm the second, and no one's gone after me, person to do a combined, oh no, actually there's a third now, a combined adult and pediatric, adult hematology, pediatric hematology, and oncology fellowship, which was a 4-year program. And the first 2 years were the clinical years. I had 1 adult clinical year and 1 pediatric clinical year. And so while I was away at Duke, they wrote a protocol based on my my mouse work for adults who have siblings who are a complete tissue match. And it was going really well. The 2 things you worry about with the transplant is that the patient could actually recognize those donor cells as being foreign and attack the donor. That's called graft rejection. But the donor immune system can actually recognize the patient as being foreign and attack the patient. And that's called graft versus host disease, which can be deadly. So it could be even worse than sickle cell. So we didn't see any graft versus host disease, and about 85% of the adults were free of sickle cells. So it was a really exciting time. But the problem was only about 15% of patients have a sibling who's a complete tissue match. So I went back to John's lab after those first 2 years of fellowship, and my goal was to develop a half-matched transplant program so that you can increase the chance that a patient will have a donor from 15% to 90%, because pretty much almost everybody has a parent or a child or a half-matched sibling who can be a donor. So as a fellow, I was given the opportunity to run a protocol, a transplant protocol. And this was back in 2009, where nobody was really doing half-matched transplants for sickle cell disease. And so that was a real amazing experience. I didn't realize that he was training me at the time to have my own lab. I didn't go to NIH to have my own lab. I went there to work with John just because I had a great time during my medical school year. And so the protocol, I transplanted really sick people that I thought were going to die if I didn't do anything, because people didn't know what the risks of haploidentical transplant were at the time. And so people were on dialysis, they had heart failure, pulmonary hypertension, and cirrhosis. So I got them all through transplant, which was huge, but it only worked in about half of the patients. So the protocol closed, and during that time, after 5 years, I was only able to be a clinical fellow with NIH for 5 years. So at that time, I either had the option to have my own lab or to try to find another person's lab to work with and just be we call it a staff clinician, which is it's a clinical researcher who implements the protocols that the PI has, the PI of the lab. And John didn't have a staff clinician position available. So what I did instead was I went on the pathway towards having my own lab, which was, it's called assistant clinical investigator. So I had only about 2 people working with me, and I had a small space, but it was great because it was my own lab. And I continued my transplant work and some other work. But after 4 years of doing that, I applied for a grant, which is called the Lasker Clinical Research Scholar Award. And I got it, and so that was in 2016. And that allowed me to have a much bigger lab. I have students, like Mahogany was in my lab as a post-bac student. She graduated from college. And then I have a postdoctoral fellow. I have a staff scientist, which is somebody who's more of a senior person who has finished their postdoctoral fellowship and stays in implements the PI's work. So since I had a lot more experience with clinical work, but not in the lab, I hired somebody that could help stay in the lab and mentor my students and fellows and troubleshoot. So, and in 2017, I wrote a new haploidentical transplant protocol where, because we saw a lot of graft rejection and not really any graft versus host disease, we added more drugs to suppress the immune system, and it worked well. We've transplanted 19 patients so far, and it's worked in 16. So it's been a really amazing opportunity. I have 2 research nurses because we've gotten pretty busy, and I just recently, as of last month, have a staff clinician, so somebody to really help with seeing the patients so that I can work on writing protocols and doing the things that the PI needs to do, travel, give talks, and write papers. So I guess I can stop there and see if you have any questions about that. That was a lot. I don't see anybody's asking me anything. So should I keep going or?
Yeah, you can go. You can go, doctor. It's good.
I want you guys to ask questions. I can't see anybody. I'm just looking at myself.
Yeah, it's the settings that we need to stay in the back, and because we're recording. But yeah, if anybody have any question, please feel free. Absolutely.
Okay. So what else? I guess I can say that my faith has been really, really important for me in getting me to this point. I felt like I was, like I said, in a direction that I thought I was going to go. But I believe that God opened doors for me to go in this other direction. And it's just like I just had to walk through the door. So that's been really important to me along this whole journey. I make sure I have time for devotion, even though I'm really busy. That helps me to be more productive during the day. So that's something that I've started doing more during the pandemic. As far as my personal life, I got married a year and a half ago. And so that was it felt delayed, but I think that it allowed me to build a lab and to, and I have somebody that's really supportive of me in that area. So that's been something that's been really good. I don't have a whole lot more to say without questions. Come on, Mahogany, ask me a question. Or she knows everything already. So I can tell you about Mahogany, what she worked on. I was actually going in a different direction initially because John is someone that, if you're on the outside of NIH, when you think of transplant and sickle cell disease, you think of John Tisdale. So I didn't know if I would be able to stay at NIH, have my own lab, and still be able to do transplant, because in order to stay at NIH, you have to be an independent investigator and show that you have your own area, your own niche. And so what Mahogany and some of my other students worked on was there's one drug that we have, or traditionally had to treat patients with sickle cell disease, and that's hydroxyurea. It has a lot of different benefits. It increases fetal hemoglobin, which that's why infants really don't have signs of sickle cell disease initially, because fetal hemoglobin keeps red cells from sickling. And it increases fetal hemoglobin, it decreases white cells, it helps to decrease inflammation. It makes red blood cells bigger so that the concentration of sickle hemoglobin within the red cell goes down. So a lot of people with sickle cell disease, even though there was only one drug available, weren't being treated with hydroxyurea. And when you take the hydroxyurea, and you take it, not only start it, but you increase the dose over time to the maximum that you can tolerate. 3 studies show that it would improve survival. And when you looked at the whole country, we saw that people were still dying at an early age. The survival didn't improve with hydroxyurea. And we realized it was because first of all, a lot of people aren't taking hydroxyurea, and second of all, they're not really dosed properly. And so a lot of patients with sickle cell disease aren't taken care of by hematologists. They're taken care of by primary, physicians, internal medicine doctors, and who may not feel comfortable treating patients with hydroxyurea, which is a chemotherapy. And so we developed we'd already used an algorithm to dose hydroxyurea, and it's based on blood counts. So you try to get the white blood cell count in more of a normal range while increasing fetal hemoglobin. And we look at white cell count, hemoglobin, and platelets to make sure we're not decreasing the counts too much. And so we developed a computer program so that when the patient comes to clinic, you just put in what their blood counts are, what their weight is, and the program will tell you how much, what dose to prescribe and when to come back to get labs. And then so when you come back and get labs, and if the labs are okay, it'll say come back. There's just this algorithm. So we tested in 10 patients and found that the algorithm was able to successfully titrate the patients to 9 of them to a maximum tolerated dose. So Mahogany presented that at one of our conferences as an oral presentation. So that was really great.
Do you have, doctor, any other passion, any other thing that inspire you to continue, or you are regularly in that road about this specific area?
Yeah, I would say what inspires me is that I love what I do. I love taking care of these patients. I didn't really talk much about sickle cell. You guys probably know about it, but this is a disease that these patients are born with. And it can be associated with severe pain. You can, like I said, organ damage. So you can have children with strokes and hip, avascular necrosis, which means their joints are damaged and they require hip replacement. Some young people need to be on dialysis, and it's a challenging disease. And it's also a disease where they're frequently misjudged, mistreated, thought of as drug seekers. So it's very challenging to have sickle cell disease. And so when they come to the NIH, the first thing we have to do is take time to really establish that trust that they haven't developed with many other physicians over their lives. So we take, some patients, it takes months to do that. And so once we do that and we transplant them, we're with them every step of the way, before they get transplanted through the process, and then we follow them long term. And it's just really amazing to see that some of these patients have had chronic pain. We're able to get them off all narcotics. We can make them pain free. Some patients are in the hospital all the time. They can't travel because they're concerned that there won't be a doctor to take care of them. They just never know when a crisis will come. They can't do things like swim because swimming can cause a pain crisis. They can be really tired, or one of the patients talked about how she couldn't even climb upstairs. And after, to transform them from that situation to being pain-free, to have energy and being able to run, to travel, to do things they've never done, I absolutely love it. So it's a really good opportunity to build relationships and to make a difference. So so I would say that whatever you do, just make sure it's something you're passionate about so that you'll enjoy going to work every day.
Thank you. Thank you. Very good.
Mm-hmm. So Mahogany said, what do you think are current barriers, if there are, with improving quality of life for these patients? I know one issue we spoke about is the stigma of them being drug seekers because of the high doses of pain medicine. I've seen this stigma here in Toledo. So that it's really unfortunate, because no matter where the patients come from, they have the same story about, patients talking about being in the fetal position in an emergency room and for hours, and nobody's taking care of them or treating their pain. So I say the biggest barrier is a lack of education. It's something that we're really working on, not just me, but the NHLBI stands for the National Heart, Lung, and Blood Institute. So there's a lot of people that are funded across the country and who are doing research, and that's one area. I know that a group in Hopkins developed this video. It's a 7-minute video where they talk about, there's 3 patients that talk about what it's like to have pain with sickle cell disease and what it's like to be treated. And it's really, really amazing video. And they showed it to students and healthcare workers and found that they were able to relate more to the patient population after they saw the video. So I think being able to, you know, you can't see, they don't have like a cancer or something or broken bone, you know, that the people can look at them and say, okay, you're in pain. It's something where you have to really develop that relationship, listen to the patients, build that trust, and just listen and just give them, or just trust that they're having pain when they say they're having pain. So I'd say that's the biggest barrier.
I have a family member that she's very young. They discovered on her that disease, and now she's going through many labs and exams, and she's doing okay, but I am so sad for her.
Yeah, it's really challenging. Where is she?
In my country, in Panama City, Panama.
Oh, okay. You know, I'm part of a group that are doing, it's an international consortium where they're doing haploidentical transplants in, I think, 9 different countries, and one of them is Brazil. So I don't know how, that's the closest I can think of to Panama. But it is amazing that even people in other countries are being able to be transplanted now.
Yeah, she's there, and yeah, she's doing okay so far right now. She's young, and maybe still 5 years.
Oh,
yeah, but let's see how things going. But thank you for this. Very interesting. I am like, oh my gosh, in shock.
Oh, no, you're welcome. So Mog is asking about the new drugs. There are some new drugs that have been FDA approved. And one of them is oxybate. I know that the generic, I think that's voxelotor. That's a medicine that it keeps the red cells from sickling, the sickle hemoglobin in an oxygenated state so that the cells won't sickle. And it's been shown to improve hemoglobin and decrease hemolysis, markers of hemolysis. So that's good for patients who have severe anemia. There's crizanlizumab, which is a selectin inhibitor, which has been shown to decrease painful crises some. So it's really nice that there are more options available for patients with sickle cell disease. There's another drug called Indari L-glutamine, which has been shown to decrease pain. And there's a lot more that are being studied. So I tell my patients this is a good time to have sickle cell disease if you're going to have it, because there's not only are there a lot of more drug companies that are interested in new drugs for sickle cell, but there's now 4 different options for cure. I talked about 2 of them, the matched sibling and the half-matched transplant, but those are both what we call allogeneic transplants, where the donor is somebody besides yourself. There's 2 new approaches that are being developed. One is gene therapy, where you take the patient's own stem cells, which are the seeds of the bone marrow, and you insert a gene into the stem cell so that it will make either normal hemoglobin or fetal hemoglobin, or it cause increases in fetal hemoglobin. And then you give those cells back to the patient. You have to give them myeloablative doses of chemotherapy in order to get those cells, those corrected cells, to have the advantage. So it's limited to the number of patients that can get it. And then the even newer approach is gene editing, where instead of inserting the normal gene, you actually correct the abnormal gene in those stem cells and give them back to the patient. And that also requires myeloablative chemotherapy. So there's 4 curative options, and then all these new drugs. So there's a lot of hope, I think, now that we didn't have before. Any other questions?
You have a question in the chat, doctor.
Okay. How has the pandemic impacted? That's a really good question. Patients with sickle cell disease. It's impacted them by, you know, it's challenging. It was already challenging enough them trying to get their treatment for their pain. So I think a lot less of them are actually going into the hospital to get treatment, so they're probably having more pain at home. Also, there was a concern initially that there would be, that the blood supply would be depleted, because some patients would get red blood cell transfusions every month, like patients who have had strokes or other indications. So it's impacted them that way. I know some doctors are putting them on lower doses of hydroxyurea that don't require a monitoring of their blood counts in order to prepare for that. And then as far as how the disease itself impacts them, there was major concern that they were going to have lung complications as a result of the SARS-CoV-2 or the coronavirus. It didn't seem to impact them the way that we thought. The mortality is a little bit higher than the general population, but not to the point that we thought it was going to be. So I think those are probably the main ways it's impacted them. And there's a lot more telehealth, of course. So. What is the most rewarding part of my position? What I said, just being able to give these patients their life back. It's actually really interesting because one thing that we didn't anticipate is that they don't know what to do with themselves after we transplant them and they no longer have sickle cell. So it's like we've created a new problem. They don't have an identity. One guy talks about how he didn't have a girlfriend, and it's because of sickle cell. He wasn't working, it was because of sickle cell. He could blame everything on sickle cell. So we have to retrain them, help them to learn how to have a different identity besides sickle cell, how to have a new life and how to really enjoy that. But once we see them actually get to that point of really loving who they are and loving life without sickle cell, I think that's the most rewarding part. Hearing the stories of how we've helped them, how definitely, multiple patients cry because they're so happy. So it's nice to be able to develop those relationships with them and just help them in a way that I didn't anticipate before, I would say is the most rewarding part. Did I miss any other questions? Okay. Do you know why there's not as much funding nationally for sickle cell research as opposed to cystic fibrosis? There traditionally has definitely been a difference in funding. I think that's more, I don't know what the current data are. Like I said, there's been a lot more drug companies that have been interested as far as grants, and I still think that there's some barriers there that I think are becoming, there's been more of an awareness about it. So I'm hoping that difference isn't gonna continue, because there's definitely more people with sickle cell in the United States than cystic fibrosis.
I have a question, doctor. Where do you see yourself 3 or 5 years?
You said 3 to 5 years?
Uh-huh.
So exactly 3 to 5 years is when I'm going to be at for 10 years. So right now, I told you I got this position called Lasker Clinical Research Scholar. That's what's called a clinical tenure track position. So the goal, if you want to stay at the NIH, is to have your own lab as a senior investigator. So right now I'm an investigator. So I want to get that. I want to get that promotion as senior investigator. I didn't tell you another big part of what I do is what a lot of people do is they transplant these patients and they're funded to follow them for 2 years, and then they don't follow them long term. So no one really knows what's happening to these patients long term. And so I'm really interested in, and I'm working with a group at Vanderbilt and Hopkins we just got a grant, a UO1 award, which allows intramural or people inside NIH to work with people on the outside in a formal way, to look at how transplants are affecting the heart, the lung, and the kidneys. And the reason we chose those 3 organs is because those 3 organs are damage to those organs are associated with early death in sickle cell disease. And also one complication that we've been seeing that's been really terrible is that some of these patients are developing leukemia. And we found that, my lab has found that when you look at the mutations that are discovered at the time of the leukemia diagnosis, and you go back to before the transplant, because we wanted to know, are we actually causing these mutations with the radiation chemotherapy that we're giving, or are these patients having these mutations already at baseline because of just having a lifetime of sickle cell disease and the stress that puts on your bone marrow and the inflammation? And we found that the 3 patients had the mutations at a much lower level even before we did anything to them. So we're going to look in a larger group of patients to see how many of them actually had these mutations at baseline and then what happens to them after transplant. We've seen it mostly in patients who lose their grafts, and so we think that the stem cells that contain these mutations are more resistant to the chemotherapy and the radiation, so that when they lose their graft, then these clones can grow over time and patients can develop the leukemia. So starting a late effects, we're calling it a late effects program, or for curative therapies after of sickle cell. So people that are getting all 4 options: gene therapy, gene editing, haploidentical transplant, and matched sibling transplant. We want to be able to look at them long term to see how the transplant's impacting those organs. And then we have there's another group looking at how it's impacting quality of life and pain and fertility. So I'm really excited that this is a whole new area that hasn't been studied with sickle cell, but it's really important, and really making sure that we're having a positive impact on them over the long term. Yeah. So there's so I told you about the clinical research training program. It's now called is that what you're talking about, the MRSP? That's what the program is now called. So if you're, you can take a year off from medical school and go to the NIH after your 2nd or 3rd year for a year. That's the same program that I did. So if anybody's interested in that, definitely reach out to me. You can either do it after your 4th year, but it would have to be after you officially, or before you graduate. You have to be a student. Let me tell them to come back. Yeah, if anybody's interested in that, let me know. That program really changed my life. I don't know if I wouldn't be where I am now if it hadn't been for that program. Oh, okay. So yeah, so for people that are interested in hematology, there's a program for my underrepresented minority, and it's not just even at all different levels. There's different programs for people who are interested in hematology. So there's one for a summer program, which is what Mahogany did. She worked with my collaborator at Children's National Medical Center in DC. They'll fund you to do research. There's other programs where you can do it for a year, even during medical school, I think even during residency and fellowship, and they even have Young Investigator awards. So we're really trying to get underrepresented minority individuals interested in hematology, because to take care of sickle cell patients, but also there's so many different areas that are exciting. So I could be happy to talk to you about that as well. I guess something else to consider is they have a loan repayment program at NIH. So I was able to get all my loans paid off while I was working at NIH.
Any other thing that you would like to share with us? How is your life after working all day? You go home and you continue at home. Sometimes a little bit challenge for us. Feel late and go home and do things at home.
Yeah, I've always felt it's really important to be able to balance your life. So I definitely work really hard during the day, but also make time for my family. So there's a couple of nights where I'll work late and try to get stuff done, but then other nights I generally work, when it's not the pandemic, from like between 8 to 9 and maybe 5 to 6. And I round on service maybe 4 weeks a year since I'm a tenure track. And then I also cover some of the outpatient clinic. So I generally, my life is I have a really well balanced life. So that was another thing that was important to me. That's why another reason I went to NIH. You're very welcome.